Good evening, participants. Thank you for joining Shield Connect today. And today we are going with the topic non-hormonal treatment for menopause. And this topic is going to get covered by our Dr. Padmini Venkataraman. And before we start with the webinar, let me give a quick intro of our page Shield Connect. So let me share my screen. So this is our page shieldconnect.in. So we have currently won 5 digital awards in women health category. So you can find there are different sections available in this page. So the first section is the blog section, where you can see all the blogs related to COVID, then gynecological topics by our eminent speakers and doctors. Then the second section is the upcoming webinars and past webinar. So in upcoming webinars, you can see the calendar of webinars that we are going to conduct. So if you click like on see more of today's topic, so you just have to register through your email ID and you can see the webinar on this page. And dear participants, you can post your queries and feedbacks in this comment section. Then you can also watch our past webinars that we have conducted in this page. So you can also go through our past webinars. Then we have special awareness pages like PCOS, menopause, GDM, immune booster, COVID-19, and thyroid awareness page. So like for today's topic, so if you want to know about menopause page, this is the menopause awareness page where you can find all the videos and blogs related to menopause. Then we have our leader section where you can find all the profiles of our speakers and top KOLs who are connected with our page Shield Connect. Then we have a special day pages like Hypertension Day, Mother's Day, Women's Day. So if you click on any of the day, you will find the videos and blogs related to that page. So this is a Shield Connect page. And now let me give a quick introduction of our speaker for the day, Dr. Padmini Venkataraman. So ma'am has done MBBS, DNB, OG, and FCIP. Ma'am is consultant obstetric and gynecologist and visiting consultant at Chennai Meenakshi Hospital, Motherhood Hospital, Orthomed Hospital, and BSS Hospital in Chennai. And ma'am has finished undergraduation from KMC Chennai, PG training from CSI Chennai, main researcher in the BRIDE trial on insulin sensitizer, and certificate course on complications of pregnancy by Royal College of Physicians UK. Ma'am has conducted a course of osteoporosis and bone health by Indian Society of Bone and Mineral Research in Delhi. Ma'am has conducted and participated in numerous health camps for women and completed course on and prebiotics, postbiotics, probiotics by the American Academic of CME Life member of IMPAI and IMA Chennai Metro. So we are glad to have you, ma'am, on our platform, and we'll hand over the session to you, ma'am. Thank you, ma'am.
Thank you so much. At the outset, I would like to thank Shield for giving me this opportunity to present the topic on non-hormonal treatment for menopause. So good afternoon, everyone. So let's move on and see what's menopause. So what's the definition for menopause? So as every one of us know, menopause is stated when a woman is not experiencing or having the menstrual cycles continuously for 12 months. So this is the main definition for menopause. So let us see some more perception of menopause too. The first one would be where the amenorrhea is accompanied by some vasomotor symptoms. And when a woman is having an infrequent light bleeding at the age of 48, and also when amenorrhea for more than 3 months in a patient, we can consider it as a menopause. And there will be a permanent loss of menstruation, and it is caused by the ovarian failure. And also, if the woman is having the vasomotor symptoms like hot flashes and night sweats. And if the woman is over the age of 51, and regardless of the bleeding pattern, you can name it or label it as a women in menopause. Coming to the terminology of menopause and also the staging, we all know that there are the main three stages, that is the reproductive, menopausal transition, where you call it the climacteric, and there or the perimenopause, and the third one would be the postmenopause. The reproductive is the first stage, where the menstrual cycles can be variable or it may be regular. Most of the time it will be regular. In the case of perimenopause, the cycles would be of a variable length. It will also be more than 7 days, and it can be different from the previous cycles, or that can be more than 2 skip cycles and an interval of amenorrhea for more than 60 days. So postmenopause, we all know that they will not be having any menstrual cycles. Coming to the endocrine picture in the first stage, we all know that there will be a normal FSH. And in the menopausal transition, the perimenopausal stage, so you can see a increase in the FSH and the derangement in the AMH. In the case of postmenopausal women, always you can see a increased FSH will be confirmatory of menopause. So, what's the hormone picture in the case of a menopausal women? We can see or say that the circulating estrogen will be very, very less. The ratio of estrogen to androgen will be less. The sex hormone binding globulin secretion will also be less. And the peripheral aromatization DHA to estrone will be increased. Whereas the reversal of estradiol, that is E2 to estrone, can also be found out. But there will be no significant change in the testosterone levels. So, whenever you take women, especially if you take her follicles as a bank, the account will always be debiting. So, whatever the follicles that you find in the embryo or while the birth, is going to be debiting. So, this is a debit account for every woman, where you find lakhs and units of follicles declining as the age is increasing. So, by the time of women attains menopause, the follicles will be nil. Coming to the symptoms of menopause, the symptoms of menopause is not the same to everyone who has attained or in the perimenopausal stage. It's quite individual and differs from person to person. It is highly individualized. So the menopause is the final menstrual period, as everyone knows, and the perimenopause or the transition of the climacteric is the time of the onset of the menstrual cycle changes until 1 year after the final menstrual period. There will be changes in the vaginal bleeding patterns. The vasomotor symptoms, which is primarily the hot flushes or the night sweats, where you can see it in the transition as well as in the postmenopausal women, but the overall experience, as I said initially, is highly variable and can be influenced by the psychological, social, and cultural factors too. So, what are the common symptoms that we see in our clinical practice? So, the hot flushes and night sweats are the major vasomotor symptoms, what we see, and the urogenital symptoms like the vaginal dryness, dyspareunia, and in many women, we can see increase in urination frequency. So, where they'll be mistaken for urinary infections, and they'll be going on from doctors to doctors, they'll be doing cultures, they'll be treated by unwanted antibiotics. So, always you have to have in mind that any perimenopausal, postmenopausal women will be having this hypoestrogenic cause, which is leading to the atrophy and dryness of vagina. And all these genitourinary as well as the vasomotor symptoms may be accompanied with mood and sleep disturbances also. So considerable mood variations can be seen in the patients coming in the perimenopausal menopausal stages. And once the mood is not in the correct order, their sleep will also be disturbed one. And these vasomotor causing the night sweats will also have the influence on the sleep patterns. So there will be a major sleep disturbance. Coming to the physical and psychological symptoms, both the things may be often related. So when there is a night sweats, and as I said earlier, there will be a disturbance of sleep, which is leading to a low mood and the reduced ability to cope with the vasomotor symptoms. And so the output from them will be automatically reduced, and their low mood will be shown by them. So which the family members have to understand and be empathetic with them. And it also depends upon the belief of the menopause, which is going to actually affect their experience. So negative expectations, beliefs, and low self-esteem are morely associated with these problematic symptoms of menopause. Coming to the etiology or the cause, it may be normal due to the natural decline of the follicles, that is the follicle exhaustion, or it may be because of the iatrogenic surgery where the ovaries may be removed. And it also may be due to radiation therapy and following a chemotherapy and a premature ovarian failure, that is under the age of 35, where their ovaries cease to produce the estrogen or the hormones. And it may be genetic, and some karyotype abnormalities can be observed with the people with the early menopause. It may be due to autoimmune, and finally it is maybe idiopathic, that is we may not be know what may be the reason for causing the menopause. So what are the key points we have to consider in treating a menopause? So we have to advise every woman coming to our clinic that it is a very, very normal event. But at about 25% of women, they have this problematic vasomotor symptoms, that is the hot flashes and the night sweats. They considerably impair the quality of life, and they will definitely be needing a treatment. The systemic hormone replacement therapy is what is currently is more effective for the vasomotor symptoms. It can also improve the urogenital symptoms like vaginal dryness. It also improves the sleep and the quality of life. So it is also our duty. Whoever is wishing to avoid HRT, we can offer them plenty of non-hormonological or non-hormone pharmacological treatments for the vasomotor symptoms. So these most non-hormonal symptoms, they act very quickly, and there will be no improvement after 2 to 4 weeks. Consider a different approach. Whenever there is a response after starting a non-hormone treatment, you can continue to do so. You can prescribe them the non-hormonal treatment, but when there is not any improvement after 2 to 4 weeks, we have to take a different approach. So as I said earlier, the menopausal symptoms it should be managed, and it should be individualized, and it should be addressed, and it should be aimed at giving the relief to the patient. So whatever the symptoms they are coming with is supposed to relieve the people with the difficulty. So the therapy should be targeting that the symptoms which it is going to affect them most, and which is going to affect the quality of life, is to be treated first and has to be prioritized and treated first. So the problems of accompanying the menopause or the vasomotor symptoms, what I told earlier, and once a woman attaining a menopause, they'll be equally prone to coronary heart disease as men, which we should not forget. And also it accompanies the very common thing that like a breast cancer. And once the estrogen level comes down, we know that the bone health goes for a toss. Their bones start having a thing, and they go for a stage called the osteoporosis. And the urogenital atrophic symptom, what we earlier discussed, like the urinary symptoms and the painful intercourse. And coming to the thing, they also have some people have dementia. So coming to the very important condition, it's called as osteoporosis. There are many risk factors for it. A family member may be previously affected with many fractures, and it could be early menopause also. They may also have family history of having early menopause, and many lifestyle habits of consuming alcohol, tobacco, and excessive caffeine intake and low calcium intake. All these is going to again increase the risk for osteoporosis. And the sedentary lifestyle. Whenever the women is more sedentary, most of them are into the IT industry or into the job it is going to where they're going to sit for a longer time. So their bones are definitely going to have the osteoporosis, and their muscles. They once the muscle is also going to go down, the strength of the bones are also going to go down. So always the sedentary lifestyle is the one thing which do not advise for the patients. And some medications, especially glucocorticoids, especially if it is given for more than 3 months, can also be a risk factor in causing osteoporosis. What are the preventive measures? So main thing would be the lifestyle changes, and the very important thing what I want to stress on is the weight bearing exercise, that it helps the patient to build the muscle, thereby strengthening the bone. When you strengthen the muscle, the bone is automatically going to get strengthened. So, a very active lifestyle is what we advise to a patient. And it's coming to a lifestyle modification, we advise to stop smoking. We also have them to have nutritional changes, that is the changes in the diet pattern. We ask them to take foods which are very rich in calcium, vitamin D, poultry, eggs, and fishes are very rich in calcium and vitamin D. So you can counsel them on their nutrition too. And if the osteoporosis is not mild, it's going to moderate changes. There are many medications for it, and the very commonly used medicines are biphosphonate, and estrogen plays a very main role in building up the bone cells. Coming to the important topic of CHD, we know that CHD is a leading cause of death in our population. So the risk for women much lower until menopause rapidly raises when the women attains the menopause. So a large body of animal and in vitro evidences show the beneficial effect of estrogen on the cardiovascular health. A large number of carefully designed retrospective and observational studies show that postmenopausal estrogen therapy results in the 50% reduction in the CHD related events. So we have to outweigh the risk and benefit before starting the estrogen, which will definitely give you a good protection to the heart. So it depends on the patient and the risk benefit ratio. And there are also so many criticisms and there's selection bias in the studies. So there may be women who are taking hormones may have a healthier lifestyle than those on the treatment. So the lifestyle, along with the treatment, they also have many lifestyle changes, including good exercises and good diet. So coming to the study by the Women's Health Initiative, sponsored by the NIH, the long-term multicentral placebo-controlled randomized prospective evaluation of the HRT. It is designed to determine whether the HRT could prevent the CHD. What are the major arms? It was including 0.625 of low-dose conjugated equine estrogen and 0.25 of MPA, that is medroxyprogesterone acetate, versus the placebo. The study was stopped after an average of 5.2 years because the excessive risk of breast carcinoma when they are exposed to the estrogen. So, what is the summary of the combination therapy arm says that it is actually the number of events per year for 10,000 patients. The patients who were on HRT, the outcome, that is the coronary HRT was observed in 37 patients on HRT, whereas in placebo it was 30. Here you can see the HRT is going to increase the coronary cases and also the stroke. The patients, that 29 patients on HRT, they had stroke, whereas It was only 21 patients who were in placebo. And what about VTE? VTE was found in patients of about 34 on the HRT and 16. So significantly, all the thromboembolic phenomena you can get associated with the patient on the HRT. And breast carcinoma was again 38, and with placebo, it was only 30 patients was having a breast carcinoma. So the risk of having a breast carcinoma increases with the HRT. And the uh, protective factor, what was observed with that is WHO study is prevention from the colonic cancer as well as hip fracture. There's no question that the estrogen improves the bone health. So the conflict with the biological and in vitro data just supporting the beneficial effects of estrogen was the main thing of WHO, except for the fact that in little patients where it gives the benefit, the HRT was giving the benefit, but the risk were also to be noted down. So the main risk of all the thromboembolic phenomena and breast cancer. So it indicates that the use of HRT in older women or for a longer period of time increases the risk of breast cancer and the CHD. So estrogen forever is no longer recommended. So a 50-year-old patient who has been having a severe vasomotor symptom for several months, she has read that the Women's Health Initiative on the internet, and it is concerned that the estrogen therapy may increase the risk of breast cancer. And now she has the right that she can ask for a non-hormonal therapy, which is safer. The results of the WHI do not apply to her. The WHI is a retrospective study and may not be valid now. Her risk of breast cancer will be minimal if she uses a non-oral estrogen therapy. Her risk of breast cancer will be lower if she adds a progesterone. So this is the point that every practicing OBGYN will be knowing. Whenever a woman is having a uterus, they are supposed to add the progesterone to the estrogens. Coming to the contraindications of the HRT, there are absolute and somewhat relative. The absolute contraindications are current breast or the endometrial cancer, past history of breast or endometrial cancer, undiagnosed vaginal bleeding, of course, pregnancy, acute and chronic liver disease, acute venous thrombosis or thromboembolic disease. And the relatives are the history of thrombosis and thromboembolism in their and a strong family history of the breast cancer. These are the relative contraindications. So here, the non-hormonal therapies they come into play where the estrogen therapy is contraindicated. So the vasomotor symptoms can be well managed with clonidine, SSRIs, herbal estrogens, and vitamin E. Coming to the coronary heart disease, the statins will be helping in the dealing with the dyslipidemia and of course aspirin, which has the blood thinning agent. And if they have the concomitant hypertension has to be treated, and the diabetes also should be treated, and the patient should be advised on the nutrition, exercise, and to stop smoking in case of a coronary heart disease. So we coming to the treatment of osteoporosis, so many SCRMs are available, biphosphonates are available, calcitonin, calcium with vitamin D, and weight bearing exercise. And again, you have to advise the stopping of smoking. What are the issues that are considered to when we are treating a patient with the menopausal symptoms? So what are the major factors? These are like age, their menopausal status, potential duration of the therapy. Whenever we are trying to plan them for a hormonal treatment, it has to be for a very short period, not a very long period. And once the symptoms are raised, we have to be withdrawing, and the severity and the impact of the symptoms, the lifestyle, and the likelihood of chance change of their lifestyle will have to be discussing with the patient. Again, the smoking comes apart. We have to stop them taking stop smoking, have a good diet, and be exercising. The other medical problems and medications, what they are on to be considered. Risk factors for coronary heart disease, where we discussed it later. And any associated diabetes, hypertension, dyslipidemia, and again going to change the course of treating it. Risk factors for breast cancer to be considered. And again, we saw what are the risk factors for osteoporosis. Again, that has to be discussed with them. The risk factors for thromboembolic phenomena like DVT should be explained to them. And what is the likelihood that they will be compliant with the medication should be considered, and the patient tolerance of the risk of it should also be discussed with them. And nevertheless, you have to be considering the cost of treatment. So what is the current situation of HRT? So estrogen replacement therapy is safe and effective in most women for at least 5 years when begin at the time of menopause. It should not be given to the women at the increased risk of CHT, breast cancer, and DVT and VTE. And this also includes the age of more than 60 years. Risk of CHD, breast cancer increases with age and duration of the HRT. So always we have to consider the fact that we have to be giving it for a very shorter period of time and with the less dosage. So use the lowest effective dose of HRT for the shortest necessary time. So we have many options for non-pharmacological treatment of treating the vasomotor part of the menopause. So where the first and foremost would be the CBT, that is cognitive behavioral therapy, hypnosis, and the mindfulness and relaxation techniques, lifestyle changes. Again, motivating them to do exercises, keeping them more active. Again, the diet and the supplements, including vitamin D and calcium. And yoga is time-tested thing which can give them the relaxation and bone strength, and also the improving the muscle. And we also, if the patient is on obese side, we have to advise them the weight loss. And our non-pharmacological intervention should be including all these factors. So what are the complementary and the alternative treatments for the vasomotor symptoms? The most popular is the CAMS, that is herbal medicine, which can be followed by soy or phytoestrogens, which will be very much in reducing the vasomotor symptoms. And the use of evening primrose also has some promising results. Again, relaxation techniques have a good effect. Again, yoga, acupuncture as a component of the Chinese medicine, where thin needles are inserted into the skin and has been extensively tested for treating the vasomotor symptoms. Once it's available to them, and if they find it very effective after doing 1 or 2, you can still advise them to continue some more sittings of acupuncture. The other method of stellate ganglion block, where you'll be injecting a local anesthetic into the sympathetic nerve fibers of the neck, which is going to disrupt the neural temperature regulation. So this is the invasive, where the procedure is very costly also. And NAMS guidance state that there's more evidence is needed for the for this, that is the stellate ganglion block, which can be recommended. So we don't use or recommend much of this stellate ganglion block. And serotonin selective reuptake inhibitors as well as serotonin noradrenaline reuptake inhibitors can be used. The international guidelines on the systemic reviews of RCTs recommended selective SSRI and SNRI for the non-hormonal treatment of vasomotor symptoms. However, the NICE recommends that these pharmacological treatments should not be offered as the first line of vasomotor symptoms alone. So let us see a comparative efficacy of the non-hormonal symptoms. So the first being the cognitive behavioral therapy, and the where you can see the reduction in the problem rating is about 47 to 52% versus 6 and 26. The reduction in the frequency was 29 to 40%, whereas in the control it was 12 to 22. What are the additional benefits of CBT? There were improvement in their mood, sleep, and the quality of life also improved. and adverse effects, nothing. So there were the people who were on CBT were not having any adverse effects. Now, what about hypnosis, where we advise the patient or put in the patient for the sleep for 5 hours? There was again a reduction in frequency of the vasomotor symptoms to 74%. And what about the additional benefits of hypnosis? It improved and interfered with the hot flushes related symptoms. It improved actually, and also it improved the mood and also the sleep. So the process of hypnosis actually relieved the patient of all the mood and the sleep disturbances, also the hot flashes problem, and there was no adverse effects noted with the patient on advising the or undertaking the hypnosis. What about the pharmacological therapies which reduce the VMS frequency? So as we discussed earlier, it is the serotonin selective reuptake inhibitors like citalopram, 43 to 50%. It decreases the anxiety and there is no impact on the libido. What about the adverse effect? So it causes drowsiness, dry mouth, and palpitation. Escitalopram of about 10 to 20 milligrams per day. The improvement was seen in 50 to 60%, whereas in the placebo it was only 30%. But there was no impact on the sexual function. It improved the quality of life. So these are the additional benefits. It improved the sleep patterns. It reduces the impact with the vasomotor symptoms. And coming to the adverse effect, sometimes it seems to increase the VMS after stopping the escitalopram immediately. What about paroxetine? That is about 7.5 to 20 milligram per day. It reduced the VMS in 41 to 60 compared to the placebo, where it was only in 14 to 38. So what about the additional benefits of paroxetine? It had a very less effect on the sexual function. And again, it improved the sleep pattern, which is a very good benefit. And coming to the adverse effect, it causes dry mouth and GI tract upset. And fluoxetine, it is a common antidepressant what we use, and it improved the VMS in about 50% of patients, whereas in placebo it was only 36. What about the additional benefits? It had again no effect on the libido. It improved the quality of life, and the mood was also improved. The serotonin and the noradrenaline reuptake inhibitors like venlafaxine extended release of about 37.5 to 150 milligrams. So again, we can see that venlafaxine, it had a reduction in VMS in 37 to 60%, whereas the placebo, it was only in 27% of people. What about the additional benefits? It improved the sleep, quality of life, and mood. Adverse effects, again, it's similar to all the things like dry mouth, GI tract upset, headache, and the very important is that it decreases the sexual function. What about dense venlafaxine? It is about 64. The improvement is seen about 64% of people, and placebo was only 51. The additional benefits, again, reduced nighttime awakenings, had no impact on the sexual function. Adverse effects, as the common other drug, what we see is GI tract upset, dizziness, insomnia. Will be higher in the first week of the treatment, possibly can also cause hypertension. So a little bit of monitoring of the BP is essential that we use venlafaxine. Anticonvulsants and centrally acting agents like gabapentin. The usual dose is about 300 to 2,700, depending upon the individual's response. The reduction of VMS is seen in about 35 to 38, which is more than in the placebo group. It again improved the quality of sleep and the quality of life. It reduced the pain, and adverse effects were the dizziness, drowsiness, increased appetite, and weight gain. Coming to the pregabalin, which is what we use commonly for many neuropathic patients. Again, the dose varied from 150 to 300. It again had reduction of VMS in about 65 to 71. And you can see that in placebo patient, it was only 50% of the patients. There was no additional benefits seen in patients with pregabalin. But again, the adverse effects would be the dizziness, drowsiness, and we may be needing a higher doses in some patients. Some patients do have cognitive problems when we treat them with pregabalin, and some people also had a weight gain. What about clonidine? So we use clonidine of about 0.1 to 0.5 milligram per day, and it reduced the VMS in 26 to 49% of patients. And the additional benefit was the improvement of quality of life. Again, the adverse effect would be dry mouth, tiredness, restless, and it, uh, it can have a interactivity with antihypertensive drugs. What are the medical alternatives we have? Of course, we know Tibolone, what we use in many postmenopausal women. It's a synthetic steroid. It has a weak estrogenic property, prostrogenic and androgenic properties. Clonidine is an alpha 2 alpha agonist, which again helps with the vasomotor symptoms. It is useful for the patients with the treatment of breast cancer. Again, SSRIs can reduce the vasomotor symptoms. Gabapentin, as we saw earlier, it reduces the severity and the frequency of the heart pressures. Progesterone may improve the heart pressures, but there are concerns about the risk of breast cancers. And Riplin's the bio adhesive moisturizer, which again has only a physical effect, which can be doing a good job of a moisturizer. And chlorine enhances the effects of anxiolytics and should not be used along with alcohol. And SSRI 60% compared to the 30%. So you can see benefits with 60% of patients where we use SSRI. And gabapentin reduces the frequency by 45%, that is the VMS, and the severity by 54%. So how do you manage a patient with the troublesome menopausal symptoms using the non-hormonal treatment? So you have to establish the nature and the timing and the most troublesome menopausal symptoms, what the person wishes to achieve from the treatment, and whether she wishes to use the pharmacological or the non-pharmacological approaches. So when you're coming to the non-pharmacological approaches, managing the vasomotor would be offering them the cognitive behavioral therapy and offering the hypnosis. You can consider acupuncture, and if all these are ineffective, you can go in for pharmacological treatments. As we discussed earlier, the pharmacological treatments would be escitalopram and venlafaxine, paroxetine, tamoxifen, and if not tolerated, gabapentin. Gabapentin is again not tolerated. We have to reconsider the review, and then review the pharmacological treatments if possible after 4 weeks, and treatment should be re-evaluated every 6 to 12 months. And you also should be considering including a specialist to refer if the patient is not responding to the treatment. And considering to manage the vaginal symptoms, what they come. What happens actually in the menopausal stage? Because of the hypoestrogenemia, the vaginal lining becomes very thin, it becomes dry, and so they experience these dryness, dyspareunia, all these things. And some patients also experience urinary symptoms. So for discomfort during sexual activity, which is very common presentation, where they come to your OP with this complaint, we have to offer them some lubricants which are non-hormonal, and also we can offer them a water-based lubricants, and you can consider using topical anesthetic to the vulva with 4% aqueous lignocane, which is a local anesthetic. So many of you would have used that also. So what are phytoestrogens? So phytoestrogens are the plants as a part of the natural defense to control the female fertility, to prevent overpopulation and overgrazing of the herbivorous animals. Let's see what are the phytoestrogens available. The main thing would be phenolics and the non-phenolics. Under the phenolics, we have isoflavonoids, flavonoids, chilbenes, lignans. Under flavonoids, we have flavones, flavonones, and carotenes. Isoflavonoids will be including isoflavones and comastins. Others would be terpenoids and sapoins. What are the food substances which are rich in isoflavones? It will be more commonly found in soybean, lentils, and chickpeas. The lignans are found in a very good amount in bean sprouts, alfalfa sprouts, sunflower seeds, spinach, and clover. Comestants are mostly seen or can be obtained by taking cereals, fruits, and vegetables. Isoflavones effect on the hot flashes is variable and can be inconsistent. So many people will tell you that after taking isoflavones, they have improved. Some people they come and tell you that it has no effect on them, they still suffer from the hot flashes. So we have to review each patient after 4 weeks, how whatever the non-hormonal or the non-pharmacological gases or pharmacological as isoflavones, whenever so we have to review the symptoms and then consider changing it. Only modest and delayed improvement of symptoms could be expected even with black potash and vitamin E. So, what other things we can advise the patient to prevent the hot flushes? It would be substituting the soy nuts for non-soy protein in the diet, which are consumed 3 to 4 times throughout the day, is associated with decrease in the hot flashes. Okay, and improvement in menopausal symptoms. 25 gram of soy protein and 1 milligram of egg glycomycin are recommended to lessen the occurrence of hot flushes. So the natural herbs and remedies for these symptoms would be phytoestrogens, that is the red clover, structural similarity to estradiol, has efficacy, whatever, or the efficacy of phytoestrogens, and the data regarding that are quite insufficient. And coming to black cohosh, it belongs to the buttercup family. It is also indicates reducing the hot flashes and other symptoms, and still the data are insufficient. And some of us can even prescribe the progesterone, and as discussed, acupuncture to be advised. What about the medical herbs? So the following are the herbs, what I'm going to state. It has a very promising results in treating the postmenopausal or the menopausal symptoms like the VMS, urogenital symptoms, the mood, and the sleep. So what are the ingredients or the main herbs? It is Synancum wilfordi. The second herb would be Phlomis umbrosa. The third would be Angelica gigas. So the active ingredient in Synancum wilfordi is cinnamic acid, and Phlomis umbrosa has the L-methyl aster as the active ingredient, and the Angelica gigas has D-quercetin and D-quercinol angelate as the active ingredient. The cinnamic acid is a natural remedy which has been used for hundreds of years in both Korea and China, and it has shown a significant improvements in the quality of women who are dealing with the symptoms of pre, peri, post-menopausal, all the three stages. And Angelica gigas is a ultrafine Angelica gigas powder found to normalize the ovarian hormone levels and has anti-osteoporosis properties in the plants. Okay. And these herbal formulations composed of the combination of Synancum wilfordi, Phlomis umbrosa, and Angelica gigas extracts have been used for treating menopausal symptoms in China and Korea for a very long time. So now we have a very fine-tuned and a beautiful product from the Shield with the tablet G100. So it has a very equal balance of Synancum wilfordi, which is equivalent to cinnamic acid of 2.57 mcg, and Phlomis umbrosa, equivalent to shanside methyl ester of about 0.129 milligram. Angelica gigas is equivalent to norokinin. It's a dried root, again 1.0023 milligram. So G100, giving in a dose of 1 BD, it actually regulates the estrogen affinity to the receptors. It upregulates the estrogen affinity to the reproductive target organs like vascular, that is non-reproductive target organs like vasoendothelium, CNS, and the bone. Acting on the or reactivating the estrogen receptors in the vasoendothelium, it reduces the hot flashes and night sweats very effectively, and it acts on the that is ear in the CNS and improves the mood swings and insomnia. Is acting on the bone, improves the DMD. And what about the down regulation of ear in the reproductive target organs? Again, in the breast, it is found not to be activating on the ER, so there will be no side effects such as breast cancer or any changes in the breast, as well as in the endometrium. So there is no question of risk in the reproductive organs. So the evidences show that it significantly reduces the vaginal dryness and reduces the hot flushes. It improves the mood swings and significantly reduces the bone pain. That is, osteoporosis also improved. So you can find the relief of symptoms after starting estrogen within 7 to 14 days. So whatever the study concluded, the subjects that of about 100 estrogen 100 group had significant reduction from 10 out of 12 Cooperman index symptoms. So the RCTs of comparing the two groups, 31 with the estrogen and 33 with the placebo, the Cooperman menopause index, that is KMI, evaluates 11 symptoms, and the mean change in the scores of vaginal dryness was significantly reduced in the estrogen group compared with the placebo group. The constituting symptoms of vasomotor, paresthesia, insomnia, nervousness, melancholia, vertigo, fatigue, and rheumatic pain were significantly improved in the estrogen 100 group in comparison with the placebo group. What about the evaluation of the effectiveness and safety of estrogen on the perimenopausal women? So when you take the parameter of osteocalcin, at the beginning of the study, it was 6.02, and after a year, it was 5.6. So there is a significant decrease in the osteocalcin. And what about the BMD? At the beginning, the score was 0.746. After 1 year, it was 0.76. So the significant increase on the BMD. And what about alkaline phosphatase? The beginning of the it was 73.35. But after 1 year of the treatment with estrogen, it was 71. So there is a significant decrease. So the study demonstrated that it improves the bone health and the other parameters regarding the bone health very much and significantly. So estrogen 100 for 12 weeks statistically significantly improved the quality of life. 9 different symptoms improved. That is the hot flush, night sweats, paresthesia, nervousness, melancholia, vertigo, fatigue, rheumatic pain, and vaginal dryness. No adverse effects were reported with estrogen. So estrogen 100 was found to be safe and effective herbal formula that can improve women's quality of life and various menopausal symptoms. And thank you very much for all your patient listening. And I'm handing over the session to the Shield people.
Thank you, ma'am, for giving all this information regarding hormonal treatment for menopause. So before we start with the Q&A session, I will check in the chat box. Till then, can I play the video of our product?
Sure,
Thank
sure.
you. Thank you, ma'am. So thank you so much for watching the video, ma'am, and everyone. So
Okay.
let me ask the queries from the comment section.
Okay.
So, ma'am, can menopause create any kind of digestive problems or changes in bowel movements?
Yes, definitely. Definitely there may be, but it may be minimal. That is not the any postmenopausal women will definitely have these symptoms of reduced gastric activity, but it can be managed with advising them food restrictions as well as some periods if indicated.
Then the second question is, how can a woman deal with the anger management occurring during the menopause situations?
Yes, 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 definitely it happens. So we should definitely consult and talk to the patients, attenders, saying that these mood swings are very it can happen with the stage of menopause. We have to advise them to go for a CBT or a counseling, and it's important to include the family members also with the thing. So the anger management will be only through counseling, not through any medicines. If it goes to other extents, maybe we can offer them a little bit of anti-anxiolytics or the depressants. So it has to be managed non-pharmacologically.
Ma'am, what is your feedback on estrogen 100? Does it
Yeah,
reduces hot flashes?
I have put so many of my patients on estrogen. So let me tell you an example of she is actually a DSP in the police. She's around 46, and she went through menopause at the age of 46, where she had no menses for continuously for 12 months. So whatever thing you said, I never I asked for the family history of any risk of fractures or something. So improved her nutrition part to increase the bone health and started her, and she also had a history of VMS in many occasions during that period of after menopause. So I put her on estrogen DD for her for at least 3 months continuously, where she had given the feedback of improvement in her mood, her performance wise it increased, her sleep was and BMS significantly was reduced with the 3 months of treatment.
It's working very good on the
Yes,
patient.
yes, definitely, definitely. VMS also the vaginal symptoms, the urogenital syndrome of menopause. It was addressing that too. So many of my patients have been benefiting with estrogen 100.
And ma'am, what is your recommendation on exercise for menopause women?
Definitely, definitely. Every woman, even in the perimenopause, even in the reproductive stage, also where we ask them to do exercise, which definitely benefits the not alone the muscle, but when the muscle is strengthened, your bone is also going to strengthen. So your mood is actually altered in a good way. So endorphins will be secreted. So exercise is what we advise in every group, not non-menopausal group, and it has helped many people.
Thank you, ma'am, giving all the answers for the questions. And we are glad to have you on our platform, and we would like to have more sessions with you in upcoming webinars on our platform, ma'am.
Sure, 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 sure.
So thanks to participants for joining for today's session, and have a nice day. Thank you, ma'am.
Thank you, thank you.